moving on to the next case, for that, I'd like to invite our moderators, Dr. V.G. Pradeep Kumar, who is the President-elect ISA, also a Senior Consultant and Deputy Chief at the Baby Memorial Hospital in Kozhikode, and Dr. Patrick Michael, who is the Associate Professor of the Stroke Center at Lucerne University at Switzerland. Welcome, sirs.
Before we start, let me welcome both the chairpersons. It's an honor. And I just want to tell everybody that I don't know whether Patrick remembers, hi Patrick, Padma here, that it is with your help and with your laws and bylaws from the European Stroke Organization that we initiated this stroke summer school way back in the year 2013. So from all of us side, from the entire executive of ISA and all the students out here, big thank you to you and welcome.
Thank you very much, Padma, for this kind introduction. Indeed, we have been very active many years ago in creating both the European summer school and then exporting, thanks to your initiative, this model to India. And I now see that your summer school is now even better than the European ones, which has been actually cancelled several times because of COVID. And you have the courage and the energy to hold the summer school in difficult situation using modern technology. So all my warm congratulations to you. I'm looking forward to this case. I'm moderating with Dr. Pradeep. And maybe Dr. Pradeep, you want to introduce our young colleague who will present the case.
Good evening, everyone. And at the outset, let me thank Dr. Padma Madam and Dr. Rohit for the wonderfully organizing this stroke summer school during the COVID times. And I thank Dr. Patrick for joining as co-chair. And this case will be presented by Dr. Ayush Mohan as per the intimation, and he will be speaking on this case first 10 minutes. And you have to stop at the stage of final diagnosis before the final investigations. And there will be some discussion part, and then you can proceed finally with the investigations and management part. So the total time is about 30 minutes. We have to be sticking on to the time schedule because programs are still to follow. I think, Dr. Patrick, we can ask our colleague to present the case.
Stop sharing. Good day to everyone. It's an honor to present this particular case on a national platform. My case is primarily a management-based case in which we face multiple challenges. So the highlight is basilar stenosis, back to the basics. So presenting my case summary, we had a 51-year-old male with history of smoking and tobacco chewing since 20 years who presented with 3 episodes of acute onset focal neurological deficits. This was on 22nd of October 2020. It was in the form of vertiginous sensation followed by left upper limb and lower limb weakness, slurring of speech and facial deviation to the left side. The second was on 25th of January 2021. Acute onset left upper limb and lower limb weakness associated with slurring of speech. And the subsequent one, third one, was on 6th of March 2021, increasing left and upper limb, lower limb weakness associated with slurring of speech. So I would be describing the first episode first time around. Patient had gone for the first 2 episodes to a private hospital, and subsequently he came to us for the 3rd episode. So he was apparently well till 22nd of October 2020, when while going to a temple in the morning, he complained of sudden onset vertiginous sensation in the form of world spinning, followed by left upper limb and lower limb weakness, onset to peak within 1 hour, and slurring of speech. At that point of time, it was also noticed that the patient had facial deviation to the left. When further questioned in the past, he had history of preceding episodic vertiginous sensation since 1 month. He was evaluated on 12th of October, around 10 days preceding the index events, which was attributed at that point of time to a peripheral, very psychogenic vertigo. And a neuroimaging was also done. That was normal at that point. So he initially went to a local hospital where a clinical possibility of stroke was kept. He was loaded with aspirin 325 mg start and clopidogrel 300 mg start. NCCT head was done, which did not show any intracranial hemorrhage. And in view of non-availability of a neurologist, he was referred to a higher center. He reached the center within 2 hours, 45 minutes of the index event. MRI brain and MRI was done, which showed an acute infarct in the right paramedian pontine territory, non-visualization of left V3, V4, and almost the entire extent of the basilar artery. The option of thrombolysis was given to them, but explaining the risk-benefit ratio, the patient and the relatives denied the same. Subsequently, the patient was referred to another higher center for the possibility of a DSA plus minus mechanical thrombectomy. So I apologize for the poor images because these were scanned and these were the images available at that point of time. This is the diffusion weighted image showing a diffusion restriction in the right paramedian pontine territory, with the corresponding ADC image showing true diffusion restriction. So he underwent DSA there subsequently after the 2 days, which showed a critical stenosis of the left V4 vertebral artery and partially thrombosed proximal basilar artery with the filling of mid and distal basilar artery from the right posterior communicating artery. So patient was subsequently started on injection low molecular weight heparin. He was continued on aspirin and clopidogrel 75 mg each, and rosuvastatin was also added. So workup for stroke was done. During the hospital stay, the general condition of the patient improved. The patient's hemiparesis and slurring of speech almost resolved within the next 2 days.
Just sorry, Ayush, was it therapeutic doses of low molecular weight heparin or just prophylactic?
Yes, therapeutic doses, 1 mg per kg, subcutaneous BD was given to the patient. I will come on to the total duration as well subsequently. So this was the left vertebral lateral run, this showing the stenosis in the V4 and the subsequent pica. And subsequently, the basilar artery was not visualized. And this is the left ICA run showing the predominant PCOM and the filling of the proximal basilar artery from the posterior communicating artery. So basic workup for the stroke was done. These were the investigations significant for dyslipidemia, and the patient also had diabetes, which was incidentally diagnosed at that point of time. Rest of the evaluation, including 2D echo and ECG, was done, which was normal. So he was subsequently discharged after 3 days. He was continued on injection low molecular weight heparin, 0.6 mg subcut VD. The total duration was around 14 days. Tablet aspirin 75 mg, tablet clopidogrel 75 mg HS, tablet rosuvastatin 20 mg HS. Along with that, he was prescribed certain multivitamins with a plan for extensive physiotherapy and diabetic diet. At the time of discharge, patient was able to do almost his usual activities, that is MRS1. So he subsequently continued on dual antiplatelet therapy for 2 months after the index event, and subsequently after that he was stopped. The clopidogrel was stopped by a local practitioner, and he was continued on tab aspirin and tab rosuvastatin 20 mg.
Sorry, Ayush, did the patient also, was he advised to stop smoking, and did he stop smoking?
Yes, sir. Yes, sir. Post the index event only, he left the smoking and the tobacco chewing as well. So 1 month after stopping the clopidogrel, he had the second event. This time around on 25th of January, he had slept at around 9:30 p.m. Then around 1:30 a.m., he had acute onset left upper limb, lower limb weakness associated with slurring of speech. Patient subsequently reached the hospital at around 6 a.m. in the morning. That is within 4.5 hours of the index event. A repeat MR brain screening acute stroke protocol was done, which showed an acute infarct in the right pons and the right midbrain. So again, slightly poor quality of images. I apologize for the same. So we can see the acute infarct and the corresponding ADC images. So patient was subsequently restarted on dual antiplatelet therapy. A subsequent re-evaluation was done for stroke. The patient and the relatives were not willing for DSA in view of financial constraints. Ma'am, he left with 1 month before the index, before the second event. So a very basic workup was done this time around. Patient and the relatives were not very willing for any other intervention. And subsequently, this time around, he was disabled when he was discharged. He recovered partially after the episode. He was wheelchair bound at the time of discharge, and he was discharged on nasogastric feeds, and he needed constant assistance for activities of daily living. So this time around, he was discharged on a higher dose of aspirin. He was advised to continue aspirin and not stop any of the antiplatelets on his own. So he was planned for a repeat DSA, plus minus stenting if at all feasible. And subsequently, in view of the recurrent stroke, he was referred to All India Institute of Medical Sciences, New Delhi.
Sorry, Ayush, I just wondered, between the first and the second stroke, there were 2.5 months. Was the LDL coming down when he came back? Do we know whether he took his medications or not?
Sir, I will show you the LDL values in our particular admission. During the outside admission and the second time around, the LDL values were not mentioned, sir. They were not done, sadly. So patient was well compliant with DAPT this time around. That is tab aspirin 150 mg OD and tab clopidogrel 75 mg OD. Subsequently, over the next 1 month, on a gradual course of physiotherapy, he had gradual improvement. He became ambulatory with minimal assistance for ADLs. He came to our outpatient department on 2nd of March. He was evaluated and he was subsequently planned for an admission and thorough re-evaluation. On 6th of March 2021, while sitting outside the ward, he started complaining of increasing left upper limb and lower limb weakness and increased slurring of speech. He was subsequently evaluated emergently. An IHS score was 6 in view of the upper limb, lower limb weakness, slurring of speech, and mild ataxia. So patient was admitted in our ward and was re-evaluated in view of recurrent stroke despite being well compliant on DAPTs. MRI brain was done, which showed an acute infarct in the ventral and paramedian aspects of the pons, right side. Case was discussed, and in view of the fact that the patient had stroked on DAPT, patient was subsequently restarted on injection low molecular weight heparin 0.6 mg subcute VD. TAB aspirin 75 mg OD was continued along with TAB atorvastatin 40 mg. Clopidogrel was stopped. So this was the image at the which was done in our institute. This shows a acute infarct in the right paramedian pontine territory, and the corresponding ADC images. A CT angiography was the vascular image. Ma'am, this is the MIP projection showing the non-visualization of the left vertebral artery along with just the tip of the basilar artery seen along with the distal and the middle portion not being visualized. So vascular imaging was subsequently discussed with our experts in stroke, the neuroradiology team, and we have critical stenosis of the terminal vertebral artery, occlusion of the basilar artery. Patient was continued on anticoagulation. Plan was to repeat a DSA after 3 months, and if at all, any particular intervention if required. So patient was discharged and explained to take injection low molecular weight heparin 0.6 mg subcute VD. He was discharged after 3 days. And TAB aspirin 75 mg HS. TAB atorvastatin 40 mg HS. I will come on to the investigation, sir. And at the time of the discharge, he had moderate disability. He required some assistance while going to the washroom and for his activities of daily living. Subsequently, in the outpatient department, he was transitioned to TAB dabigatran 150 mg OD BD along with TAB aspirin 75 mg HS. So this was the investigation. The LDL was still slightly on the higher side, not the target LDL which we expect in a stroke patient, that is 100. And the cholesterol was also raised. And rest of the investigations, the HbA1c was 5.9 at this point of time, which had improved. Yes, ma'am, hemoglobin was 16.5. And rest of the workup for stroke was negative, including 2D echo and Holter, which was done at RMC. So he was again admitted recently with a plan for a repeat DSA. At the time of the this particular admission, patient was fully ambulatory with minimal residual disability. He was able to do all his activities of daily living with minimal support. During the preceding 3 months on anticoagulation and antiplatelet, he had no fresh TIA or stroke. So the DSA patient was planned for DSA. The DSA was done and the procedure was uneventful. I will show you all the MRI findings in this particular admission in the DSA. So the MRI, the flare imaging showing a residual chronic infarct, the residual gliosis of the particular old infarct. So the left ICA, the vertebral run was not optimal because of certain technical challenges faced by our neuroradiology team. So I'm only going to show the left ICA run, lateral run. So then this, as we can see, the PCOM is just the tip of the basilar is visible. And rest of the basilar has also vanished. And the vertebral artery, I will mention the findings, was just after the V4, it was not visualized at all in this particular DSA. So this was the MR imaging with contrast, which was done, which is showing a eccentric contrast enhancement in this particular basilar artery, suggestive of chronic occlusion.
Yeah, Ayush will present it. The first presentation, patient had weakness of left half, left upper limb, lower limb with the deviation of face to same side. So
yes,
just start from the clinically. How are you going to explain this?
So patient had crossed hemiparesis because since the patient had facial deviation to the left side, it is signifying that the facial muscles, that is the facial nerve on the right side is affected. cross paresis. So he has cross hemiparesis. Facial weakness was on the right side. That is why the facial deviation to the left side. That is the same side of the hemiparesis. So that is why it is a crossed hemiparesis.
No, the weakness was of the left upper limb, lower limb, and facial deviation to left side.
Yes, sir.
Okay. So you mean to say it's to do a midbrain lesion? So you showed a corresponding midbrain lesion in the first episode, midbrain infarct.
So first episode only had an infarct in the right paramedian pontine territory. The midbrain was the second one, but clinically he had no signs of midbrain involvement in the form of either gaze paresis or any other ataxia.
Basically, this is a case of many challenges. No, I think Dr. Patrick will be leading some more discussion. The clinical aspect, any more questions to be covered in this? And then we'll go to the investigations and management part.
Well, I think so. It was not a crossed syndrome. It was all on the same side, the hemiparesis. Yes, okay. Well, of course, a pontine stroke can give you both. Can either give you a pure unilateral hemiparesis, all on the same side, or it can give you a crossed syndrome that is facial paresis on one side that looks like a peripheral facial paresis because you have either the nucleus or the fascicle of the seventh nerve, which is paralyzed, and then the hemiparesis on the other side. So in this case, it is a lacunar stroke syndrome, and clinically the only clue why it is rather the pons that is in the brainstem and not supratentorially was really the vertigo. So he apparently had quite important vertigo, which then of course would localize the lacune in the brainstem. So the interesting thing, of course, is that it is clinically and radiologically a lacunar stroke syndrome, a perforating artery. But of course, we have all these major abnormalities on the basilar artery, which is occluded proximally, and also the distal vertebral distal artery is also suboccluded. So, as you know, lacunar strokes, both clinical stroke syndrome and lacunar radiological strokes, can of course be due to true lacunes, so due to true occlusion of just a small perforating artery. But of course, it can also be due to large vessel atherosclerosis, which then would occlude the orifice, the opening of the little perforator artery, which is the case here. So although clinically and radiologically it's a lacunar stroke, pathophysiologically it's a large vessel atherosclerotic stroke in a patient with three major risk factors, which are diabetes, cholesterol, and tobacco use.
And to add that, there is some fallacies in the NHS scoring system also in posterior circulation, which many a time you can see that fallacies happens in that when you calculate NHS maybe a low score, subsequently you may find a bigger vessel occluded. I think Dr. Patrick would agree with that.
Sure, yeah. So I think the diagnosis and risk factors are quite clear, or do you want to do, so I think you can go and talk about management, both acute management and also prevention. What would you like to talk about first?
So the approach to basically this was a chronic symptomatic recurrent basilar artery occlusion in a patient with four risk factors, dyslipidemia, smoking, chewing tobacco, and subsequently diagnosed to be diabetes. So the basilar artery occlusion, any brainstem stroke can present in three ways. One can be a sudden onset maximum peak, usually attributed to embolism, and it is usually seen in patients with tip of the basilar artery embolism, which is commonly seen. Another particular presentation is preceding history of some very trivial symptoms like dizziness, nausea, headache, and yawning, followed by a progressive stuttering type of symptom with a maximum onset, which is slightly delayed. So this is normally a course in patients seen with an atheroembolic kind of a disease, atherosclerosis. And the third type is locked in the severe brainstem syndromes, the locked in state, the tetraplegic coma that we normally fear a lot. So this was the case which was fitting more in second. The thing was, I felt that since this patient had a recurrent stroke in one particular territory, and it seemed like a chronic obstructive chronic basilar artery occlusion. He had good collateral circulation, and that was the possible reason because of which he never had a very large infarct. and the collaterals were the one which were possibly preserving the most of the brain tissue in that area. So,
can I just interrupt here? Do you think that patient was when switched over to single antiplatelet like aspirin alone by the local practitioner, he developed a second stroke? So, do you think that it is due to an aspirin resistance?
Sir, so we can't be sure, but possibly not. But since it is in the natural history of posterior circulation strokes, as per the subgroup analysis in the VASIT study, we know for a fact that posterior circulation strokes have a different history as compared to anterior circulation strokes, and they usually, even on antiplatelets, might not respond well. The figure quoted are somewhere in 30 to 40%, although it's an old data. So that is why from whatever I have an understanding of the posterior circulation strokes, it is a gray zone. So the optimal management as of now is still not clear, whether antiplatelets or anticoagulation.
And the role of heparin?
Sir, heparin, if at all, we have a very strong suspicion for cardioembolic on the basis of either clinical factors, risk factors, and along with that, the concomitant neuroimaging findings. Then heparin has a strong role. Or again, if we have a very strong suspicion for atheroembolic disease, as in a young patient with history of neck trauma presenting with dissection, vertebral dissection, subsequently embolizing to the basilar artery. In those particular cases, acutely heparin definitely has a role. Subsequently, in another subgroup of patients, as we've seen in this case, we know that patients on anticoagulations do better, but at the same time, there is always the risk of increased hemorrhagic complications.
Dr. Patrick's comment on this, on heparin on acute stroke, because here it was given heparin, low molecular heparin in the first episode, second episode from outside. He received heparin. So any comment on this?
So we should probably separate the hyperacute treatment, which is aiming at recanalization, that is thrombolysis, thrombectomy, and then we should talk about secondary prevention, early and chronic secondary prevention. So I think for acute treatment, recanalization treatment, this patient, in my view, he had 3 strokes, and actually all of them were severe, sufficiently severe, disabling, which would all of 3 would have justified thrombolysis. Now with the second one, he came in too late, so there's no reason there to thrombolyze. But with the first one, thrombolysis was offered and the patient declined. Just explain me, I know that a frequent reason for not doing thrombolysis in India is that patients don't or can't pay for it. Do you think, was this the reason why he didn't want thrombolysis, or was he afraid of the complications?
So the relatives and the patients together refused when they were told of the risk-benefit ratio for thrombolysis.
So, of course, this is an educational problem. I mean, thrombolysis, we all know, within the first 4.5 hours is, of course, efficacious and has many more benefits than risks. So this patient, unfortunately, did not understand the benefits and the risks of medical treatment. And it's interesting because it really virtually never happens in my hospital. I think I've seen 1 or 2 patients of about 1,500 thrombolysis cases over the last 15 years who have refused. So it is interesting to me, and some people used to think that strokes in the posterior circulation or the posterior fossa should not be thrombolized because if they bleed, of course, the risk of herniation is higher, which is true. But in fact, several analyses have shown that posterior fossa actually bleed much less because the volume of stroke is usually much smaller. So there's really no scientific reason at all to withhold IV thrombolysis in posterior circulation stroke. And it's a little bit of a pity that this patient and his family didn't understand that. But of course, this can happen. So then the third stroke should also have been thrombolyzed. And I didn't understand the in-hospital stroke in New Delhi that happened under the eyes of the medical personnel with an NHSS of 6, hemiparesis. You didn't mention it, but why was it not thrombolized? He had quite rapid MRI. Of course, at this time, he was under, I think, double antiplatelets, but this is not a contraindication for IV thrombolysis. was it considered or not, IV thrombolysis in the third stroke, in the in-hospital stroke, or do you remember why it wasn't done?
You answered it.
So in the third particular event, initially by the time he was worked up and he was referred to the emergency, so there were certain technical barriers because of which he was not thrombolized. Initially, it was thought that the weakness he had and the slurring he had was very subtle as compared, because he already had a residual deficit. So initially, that is why the take-home message also, which I feel should be from this particular case, is that the posterior circulation strokes are very, very subtle, very, very insidious. They have to have a very high index of suspicion. So in this particular case as well, initially it was in the third particular event, it was felt that the patient is not having a increasing weakness, is not having a fresh event. That is why there was some time delay.
Good. Okay. So, well, it happens to all of us that we, sometimes miss thrombolysis possibilities. Now, the next question is again of endovascular treatment in the acute phase. As you know, both the BEST study and the BASIC studies were negative. They didn't prove that endovascular treatment within 6 hours did have any benefits. And in particular, in the BASIC study, this was particularly true in patients with not very severe basilar artery occlusion strokes, like this patient and an NHSS below 6, 8, or 10. They didn't seem to have any benefit from endovascular treatment. So it was, in my view, correct that this patient was not offered endovascular treatment, even if this would have been available. And then in the more severe strokes, maybe there is some benefit for endovascular treatment if given early. So this is the current knowledge about endovascular treatment in the acute phase for basilar artery occlusion.
Patrick, one question though is that, so we are not aware of this case. This must be some case that he's picked up. But the things that probably will have to come probably from, I'm also seeing this case for the first time. So from what I see is that one is probably, as he said, that picking up subtle deficits in a posterior circulation event may have been missed, and probably therefore the third event may not have been diagnosed as a stroke in the right time interval. That is what I assume is the reason why an acute thrombolysis was probably not offered. But the more important question that I have, Patrick, too, in fact, all the, both you, Dr. Pradeep, and I can see Dr. Majaz, is could we have prevented this? I mean, shouldn't he have been offered, a stent right in after there was an event, the second event itself, instead of assuming that it is a compliance issue and he should be on a long-term anticoagulation? And now that we have all the arteries which are blocked, how long is he going to be on a combo of an anticoagulant with a low-dose aspirin? So what is your take on that?
Good. So I think you're really facing a patient with severe atherosclerotic disease and probably not yet best medical treatment, and that's why he has these recurrent strokes. It's really a severe situation, isn't it? So for secondary prevention, what works and what doesn't work in this situation, like in any atherosclerotic stroke, what works in the acute phase, in the acute early secondary prevention is double antiplatelets, which you gave very nicely. And if you give aspirin and clopidogrel, don't forget to load both of them. So give whatever 300 or 500 milligrams of aspirin load, and also give 3 or 6 tablets of Plavix of clopidogrel right away, and as soon as possible, both of them. So double load, and then if you keep them for 3 weeks, it's probably enough. There's really no evidence that beyond 3 weeks it's useful. The benefit is really in the first 2, 3, 4, 5 days, maybe 7 days, and after that the benefit is pretty much gone, and certainly after 3 weeks, maybe after 10 days already, there is no more benefit. And as we know from the MATCH study, long-term double antiplatelets is not useful in this patient. So I think you did right to stop each time the antiplatelets. We stop them after 3 weeks, and then you just keep them on monotherapy. We prefer a little bit clopidogrel over aspirin monotherapy, but this is not very important. So that's the acute management, double antiplatelets, double load, very important. I don't think acute anticoagulation was justified.
Just an addition, Dr. Patrick, what about the statin 80 milligram versus 40 milligram?
Yes, of course. I mean, the goal is to lower this LDL as much as you can, you know. I mean, whatever means you have, I personally would start with 80 milligrams of atorvastatin. If I'm not sure you have ezetrol in India, it's not very effective, but if whenever possible, I would add it. I know you probably have PCSK9 inhibitors, but they're terribly expensive, so nobody can really afford them, even here. So, but at least with high dose statins and ezetrol as well, you should go as far as you can. Blood pressure was apparently not.
Really so my question really is that when there was a second episode with a severe basal artery stenosis, every guideline recommends that this is a time for intervention, not continued medical therapy. Secondly, anticoagulation really has no role in this. This has never been proven to be of any efficacy. You know, it's not effective. It's not used commonly. Now, people may use it off-label. That's the difference. But I don't understand why he was not offered stenting the second time when he was acquiring that.
Let me answer to that. Let me share my screen here. And as you can see, this is the meta-analysis of Professor Marcus, which was published 2 years ago in Lancet Neurology. So as you can see, on the left side, you have the meta-analysis of randomized studies of extracranial stenosis of the vertebral artery, okay, right or left. And you can see in the medical group, there are, can you see my slides?
Yeah.
Yeah, okay. The medical group, there seem to be a little more recurrences than in the stenting group. So what you say, Dr. Majas, it's maybe right, but they say this difference is far from significant. So we're not sure yet whether even for extracranial stenosis of the vertebral artery, stenting really works. Now on the right side, you can see that stenting actually is having a worse outcome if you have an stenting of intracranial vertebral artery disease. So either V4 stenting that you would need in this patient or basilar artery stenting, as you can see, it has, especially in the very early phase, a very high rate of recurrences, more than medical group. So from this meta-analysis, you can really say it is wrong to offer stenting. Of course, you will tell me, well, this is the second event or maybe a third event, but we know from the other anterior circulation intracranial studies from the SAMPRI study, they did subgroup analysis of recurrent strokes who were only stented for MCA stenosis with the second or with the third stroke. And even in those patients, there was no benefit at all. So I don't think that we can say with the data we have that stenting is a good option for this patient. You can see this is the early recurrence here. This is the early recurrence rate of stenting in the first few days, and it's just terribly high for intracranial disease. So really, even after second or third stroke, in this, I don't think that stenting is an option, really.
I think Ayush can complete that presentation.
So in the SAMPRIS trial, which was only for, I mean, the idea was to try stress medical management for the first phase, because better than the stenting. But it was not designed to answer the question of recurrent strokes. It wasn't designed to answer the question, what happens when somebody has a repeat recurrence. So therefore, it cannot be taken as, you know, and then this is why when you fail medical treatment, which should be the first line treatment there, absolutely. But when you fail medical treatment, and of course you're talking apples and oranges because we're talking about anti-circulation symptomatic stenosis versus posterior circulation. But there have been enough papers after that showing that posterior circulation does not differ very significantly from the anti-circulation, as you said before. Which is why I mean, at least that's what we practice.
Yes, Ayush, you can complete that presentation.
So the final diagnosis, recurrent stroke, posterior circulation territory, etiology, large artery atherosclerosis, chronic basilar occlusion. The risk factors were ex-smoker, tobacco chewer, dyslipidemia, and diabetes. Thank you.
Don't think that's due to vasculitis?
Sir, unlikely because of the fact that he had no preceding history of headaches, no features suggestive of vasculitis per se, and
Exactly.
we got the contrast enhanced images as well. That was suggestive. That was showing a eccentric enhancement in the vessel. So, keeping in view his vascular risk factors as well. So we felt that it was more because of large artery atherosclerosis.
Did you consider triple antiplatelet in point of time?
Sorry, sir?
Triple antiplatelets?
Sir, no, sir. Never. Not in this patient, sir.
I would like to have some comment from Dr. Patrick also on this. Some people add silestazole as well sometimes.
Well, you could, again, it's more experimental. We don't have good comparative studies of silestazole compared to aspirin. It seems similarly effective, but if you add it to aspirin, we don't know whether it's better than aspirin alone. So I'm not against it because silestazole has a relatively low bleeding risk, but you don't know. You really have to discuss it with the patient and have his agreement.
Thank you. Any more questions or comments?
What do you think?
Yes, sir.
Vedanta?
Hello, hi.
I should be here.
Yes, sir. Sorry.
Ticagrelor. Vedanta adding insipidazole.
Ticagrelor. Adding ticagrelor to
Yeah.
Sir, no idea about that. So third antiplatelet. I will.
No. He's not asking about third. He's asking
I'm
about
saying that
adding aspirin and ticagrelor. Vedanta is ticagrelor.
Yes, sir. So I've not used, and I don't know, sir, about this particular.
No. This is asking in view of the Thales trial publication. So the use of ticagrelor and aspirin. So that's also in Thales also was a large artery, right? High risk, large atherosclerotic disease. But your case doesn't fit there, no? So you should know about Thales and then answer him as to how can you actually take those spin-offs from a Thales trial and talk of ticagrelor versus. You know about Thales?
No.
He doesn't know about Thales.
So
that's okay.
Dr. Patrick, I just have your comments also on because since the patient is suppose this patient is opting for only for medical treatment, what optimal medical treatment would you advise in the patient?
So in terms of medical treatment, again, in the acute phase, in the first 3 weeks or so, you would have to do double antiplatelets. That's aspirin and clopidogrel, like you did, or aspirin and ticagrelor. That's okay as well. After 3 weeks, I would give clopidogrel alone. And I would do as high dose statins and ezetrol as possible. That is the highest dose rosuvastatin or atorvastatin he has, and ezetrol. If you have PCSK9 inhibitors, you give them, but it's much too expensive. And then make sure the blood pressure is fine. Then there are all the soft risk factors you should treat. The patient is able to walk, so he should do regular walking and exercise. You should treat his sleep apnea. You should reduce his weight. You should treat his diabetes. Remember, there are now new diabetes drugs that reduce the risk of strokes, the SGLT2 inhibitors and so on. So don't forget that. Then that's the best you can do. I don't think you can do much more.
Thank you. I think time is running out, and thank you, Dr. Patrick, for chairing the session, and thank you, Dr. Ayush, for presenting this wonderful case, and thank you, the organizers, Dr. Padma Madam and Dr. Rohit, for inviting us for chairing session. Any comments, final comments from Dr. Patrick, please?
Thank you to everybody for a very nice case. Dr. Ayush, very, very good presentation. Many thanks.